Afidane, good morning. The Committee on Health, Tourism, Military Affairs, and Senior Citizen now convenes this public hearing. Public hearing notices were provided to the media. First notice on Thursday, December 7, 2017. Second notice on Tuesday, December 12, 2017. For the record, today is Friday, December 15, 2017, and the time now is 11:04 a.m. The committee will hear testimonies on Bill 201-34, an act to repeal or reenact Sections 12.313, Chapter 12, Division 1, Part 1 of Title 10, GCA, and this is relative to policies within the administrative rules and regulations of the Guam Board of Nurse Examiners. Bill 202-34, this is relative to expanding access to physicians' professional profiles. I'd like to recognize Vice Speaker Tulahi for being here. Thank you very much. Senator Torres, prime sponsors of the legislation, and Senator Lee, thank you very much for joining me this morning. We'll start off with Bill 201, and for those who have signed up to testify, as I call your name, I ask you to please come forward and take a seat on the table in front of us. Ms. Rose Greeno, Ms. Carla Haddock, Dr. Kevin Haitosis, Greg, can't really read the right, sir. Steph Tyron, and Ashley Arceo, or Artero. Thank you. I'd like to now recognize Senator Torres on Bill 201.
Thank you, Mr. Chairman, and good morning, everyone. Thank you very much for being here today for this public hearing. Bill number 201-34 is an act to repeal and reenact Sections 12.313 of Chapter 12, Division 1, Part 1, Title 10, Guam Code Annotated, and to repeal and reenact Article 5 of Chapter 6, Title 25, Guam Administrative Rules and Regulations relative to policies within the administrative rules and regulations of the Guam Board of Nurse Examiners. Bill 201-34 is a piece of legislation that seeks to modernize the Guam Nurse Practice Act by bringing the law governing advanced practice registered nurses in line with national standards. This legislation provides full practice authority for APRNs, which will allow them to evaluate patients and prescribe medication under the exclusive licensure authority of the State Board of Nursing. I want to thank the subcommittee, the APRN subcommittee for the Nurse Practice Act, in working with me to align the Guam Nurse Practice Act and the Guam Nursing Rules and Regs with national standards. For the public, currently there are more than 40% of the states have adopted full practice licensure authority. And this bill follows the recommendations and guidelines of that APRN model that was designed by the National Council of State Boards of Nursing. But I believe that it's timely that we do this because modernizing Guam's Nurse Practice Act will ensure that all APRNs meet the uniform requirements and that the proper standard of care is available to our island community. And with that, I turn it over to you, Mr. Chairman. Thank you very much.
Thank you very much, Senator Torres. Ms. Rose Greeno, recognize you.
Good morning. Dear Honorable Dennis Rodriguez, Honorable Mary, practitioners play in our complex healthcare delivery system. The bill recognizes the essential role that nurse practitioners play in our complex health delivery system. Currently, there is a shortage of primary care providers in our island, and many people wait for weeks to see primary care physician or specialists, and maybe you senators have experienced there's a long wait for an appointment. Nurse practitioners are really working to provide needed primary care services, but they have reduced practice authority in this jurisdiction. despite the overwhelming evidence that the nurse practitioners provide a safe, high-quality, and cost-effective health care. They are still unable to practice to the full extent of their graduate education and clinical training here in our island. I ask you to support full practice authority for nurse practitioner in Guam, and I ask for a favorable vote for this Bill 20134. Thank you so much.
Thank you very much, Ms. Carino. Ms. Carla Haddock.
Hafa Adai Senators. I actually first have a letter written by the American Association of Nurse Practitioners that I'm going to read into record and then submit. It says, Dear Senator Torres, the American Association of Nurse Practitioners, AANP, appreciates the opportunity to respond to your request for formal comment regarding Bill 201-34. This legislation will bring Guam in closer alignment with national nursing licensure recommendations, and as a result, improve access to care. On behalf of our Guam membership and their patients, AANP recommends supporting this legislation. Guam, like other U.S. territories and states, faces challenges in ensuring patients receive access to timely, cost-effective health care services. Compounding the challenge is Guam's outdated and unnecessary statutory requirement that a nurse practitioner maintain a collaborative practice agreement with a physician and before patients may assess nursing care, and that an APRN complete an additional 1,000 practice hours following the successful completion of advanced practice nursing education program in order to apply for prescriptive authority. These requirements needlessly bottleneck the island's healthcare workforce, inhibit provider recruitment, and prevent patients and programs from capitalizing on the full benefit of nurse practitioner services. There is a compelling evidence to support Bill 201-34, adopting the recommendation to bring Guam into alignment with regulatory model endorsed by the National Council of State Board of Nursing, the evidence-based recommendations of the National Academy of Medicine, formerly the Institute of Medicine, and endorsed by the National Governors Association. NPs have a proven track of regulatory safety that's in step with future models of care delivery. 22 states, the District of Columbia, including Hawaii and the Northern Mariana Islands, have already adopted similar licensure and practicing laws to those proposed in Bill 201-34. Many of these jurisdictions have had this regulatory model in place for nearly 2 decades and lead the nation in advancing patient-centered healthcare models and other innovative systems of care delivery. Right-sided licensure laws ensure individual clinician accountability and the platform for innovation and flexibility to deploy the healthcare workforce in ways that best meets the needs of our community and patients. Research has also demonstrated that states that adopt full practice authority continue to not only have safe health care for their citizens, but better health outcomes as well. In 2014, a study published in Nursing Outlook found that Medicare and dual-eligible patients have lower hospital admissions and better health care outcomes in states that have adopted full practice authority than those who have not. States with full practice authority are also more likely to have nurse practitioners serving in rural and underserved areas. Bill 201-34 will make a significant difference for the many Guam Islanders who face significant challenges in accessing healthcare services. Nearly 2 decades of research show correlations between practice law and the distribution of NPs into underserved areas. States that adopt full practice authority for NPs have shown beneficial healthcare workforce trends. Arizona retired their version of an attestation requirement and transitioned to full practice regulations for all elements of NP practice in 2001. Workforce trend data from the Arizona Rural Health Office, looking at the first 5 years following this regulatory change, demonstrated a significant increase in the number of NPs in the state and in serving in underserved areas. According to the AARHO report, the number of Arizona licensed NPs in the state increased from 52% from 2002 to 2007, with the largest percent of NPs occurring in the rural classified countries. States that have more recently adopted full practice have also seen similar growth in their workforce. While there is no single solution that will solve all of our island's healthcare challenges, adopting Bill 201-34 to bring Guam nursing licensure law in line with the standards recommended by the National Council of State Board of Nursing is one critical element that can make an immediate and tangible difference. On behalf of the AANP and our Guam membership, we fully support Bill 201-34 as introduced. Guam needs proven solutions like those contained in this legislation to effectively meet current and future healthcare requirements. A fundamental cornerstone of future healthcare delivery will be effective regulation and flexible deployment of the MP provider workforce. Signed, Tay Kopanas, DMP, AANP Vice President, State Government Affairs, and Jamie Kings, AANP State Policy Analyst. I also have a short testimony from Lena Leishman, who's an NP working at GRMC currently. She's off island and was unable to be here, but she wanted to make sure her testimony was heard. She states, I am a new family nurse practitioner. I was licensed in Virginia, but chose to relocate to Guam to start my career. The state I was licensed in does not have restrictive prescriptive authority, and APRNs can apply once a collaborative agreement with a supervising physician is in place. I was surprised to come to Guam and find that that is not the case here. This restriction has complicated the care I provide to my patients. I practice independently with a supervising physician, meaning I provide care and treat my patients mostly independently, outside of medications right now. All of my medications have been ordered in the EMR and co-signed with a verbal order by a physician, possibly delaying administration and confusing the pharmacist as to who to communicate with regarding orders of medications. When discharging patients home, the process can be delayed when waiting for physicians to co-sign prescriptions. I will continue to have a supervising physician to use a resource when I was concerned about a treatment plan or had questions. Taking out the restrictive authority practice currently in place will not take away from using my clinical judgment in the manner. Modernizing this bill to allow APRNs to practice to our full extent not only brings Guam up to speed with the rest of the mainland states, but also allows me and other licensed APRNs to provide more efficient care to our patients. And finally, my testimony. I am currently a nurse practitioner student in a dual role of family nurse practitioner and acute care. I'm set to graduate in May of 2018, so in a couple of months. Guam's outdated regulations really hinder patient access to high-quality nurse practitioner care. These unnecessary restrictions impede the island's efforts to ensure timely, cost-effective, and quality primary care services. And I believe much of the opposition that I've read online from states that have failed to pass it through comes from misinformation or non-information, and not necessarily because they really oppose the bill itself. Eliminating the written collaborative agreement does not mean that we are really eliminating the collaborative agreement. I mean, Guam has such a unique healthcare system and such a unique relationship with our fellow healthcare providers that we're constantly looking towards each other, and we're not going to eliminate that collaboration with other healthcare providers. It just means we're eliminating the formality of the written agreement. We really represent the Hafaday spirit and help each other out. MPs will still collaborate with each other, with other physicians, and with other healthcare providers to optimize delivery of care. The 1,000 hours required before prescriptive authority is granted is really not necessary. Our clinical hours, what I'm training to do right now, helps us to train us to correctly write the prescriptions. MPs are regulated at the federal and local DAA levels. Can you imagine how practical it would be, and I've seen this during my clinical hours, to have an MP see a patient, treat a patient, write a prescription, leave the room only to have to find another physician to countersign that prescription, and then come back into the room prior to discharging the patient. Physicians aren't always available when we need them, and that's just the flow of the patient systems. It's really unnecessary and cumbersome. Many centers of excellence stateside utilize NP to spearhead specialized clinics, such as heart failure clinics and diabetes clinics. If you look at MD Anderson, they have a wonderful endocrinology program that's set up, run entirely by NPs. And as we know, much of these specialized clinics are needed here on Guam. GMH already utilizes CRNAs, the Certified Registered Nurse Anesthetist, to their full capability. Why not extend it to the rest of the NPs on island? And further, multiple studies have demonstrated that nurse practitioners are safe. There has been over 100 studies comparing outcomes, care outcomes for nurse practitioners and physicians for the past 40 years. Without any exception, all of the studies found that nurse practitioners and physicians provide equivalent care in regards to safety. In fact, these studies have shown NPs have the same or better patient outcomes when compared to physicians. I'm really asking for all of you to please rally with your colleagues to pass this bill because I believe it is very much needed in Guam's healthcare system. Thank you.
Thank you very much for those testimonies. Dr. Haitosis?
Good morning, Senator Rodriguez, Senator Torres, Senator Talahi, and Senator Lee. My name is Dr. Kevin Haitosis. I am a lead primary care nurse practitioner for the Department of Veteran Affairs home-based primary care program. I'm also the president of the Guam Board of Nurse Examiners. The recognition of advanced practice nurses in Guam in providing high-quality health care to the island community is long overdue. A significant issue facing APRNs in Guam is the restriction in which a nurse practitioner cannot practice to the full extent of their education and credentialing. The outdated requirement mandates that APRNs possess a written agreement with a collaborating physician, constraining the APRN to a regulated relationship to an MD. This restriction can be akin to the requirement of having training wheels for a road cyclist. This statute has been in existence for over 34 years in Guam, and it is now time to allow APRNs full practice authority in the 4 roles of nurse anesthetist, nurse midwife, clinical nurse specialist, and nurse practitioner within their scope. Among APRNs, nurse practitioners play an essential role in the delivery of quality healthcare in Guam. Most nurse practitioners are primary care providers, all of whom are nationally board certified, have earned a doctorate or a master's degree on top of their years of experience as a registered nurse. Many nurse practitioners were specialty nurses in the ICU, emergency care, or primary care setting before they began their graduate nursing education. All advanced practice nurses have been trained in the clinic or in the hospital by physician colleagues, physician assistants, or a fellow APRN. Advanced practice nurses such as nurse midwives and nurse practitioners have worked in our public health system for decades. Nurse anesthetists have administered anesthesia care at Guam Memorial Hospital for just as long, and many nurse practitioners have worked in a variety of fields from family medicine, emergency care, oncology, cardiology, and pediatrics. They are all equipped in their area of expertise to evaluate patients, diagnose, order, interpret diagnostic studies, initiate and manage treatments, which includes the prescription of medications. Presently, the Guam Nurse Practice Act limits an advanced practice nurse in setting and scope of practice. It requires a medical doctor's supervision or use of protocols and delegation or team management by a physician. In order to practice, a nurse practitioner must find a collaborating physician. For the nurse practitioner new to our jurisdiction seeking a job, this becomes a barrier to obtaining a license. Without a collaborating MD, an APRN license cannot be issued. This results in a delay in NP licensure and ability to practice. Another complication of this requirement occurs when an MD leaves the practice or when an NP changes jobs. The APRN must cease practice until a new collaborative practice agreement is completed. Yet another significant barrier to entry practice for the novice nurse practitioner is the requirement for 1,000 practice hours needed to apply for prescriptive authority. The APRN cannot prescribe medications or treatment until this requirement is met. In the meantime, the nurse practitioner would have to seek out the collaborating physician for a signature of the script in between patient visits. I therefore offer my strong support of Bill 201-34, which would repeal the requirement that an advanced practice nurse have approved attestation for collaboration and consultation with a physician. The bill would also remove the requirement for an APRN to complete 1,000 practice hours prior to applying for prescriptive authority. This legislation would allow APRNs to practice to the full extent of their education and clinical skill. Those who oppose this full practice authority are concerned that the removal of the language regarding an agreement to collaborate would destroy the working relationship between an NP and MD. Some may recommend that a failure to collaborate is a cause for disciplinary action. In actuality, advanced practice nurses are obligated to collaborate with other healthcare clinicians according to national standards, and collaboration is the norm. But collaboration is not forced upon, nor is it dependent on a written document. There is no evidence regarding patient safety with the elimination of the regulated collaborative agreement. There is strong evidence to support Bill 201-34. Evidence-based recommendations for full practice authority comes from the Institute of Medicine, the Macy Foundation, and the National Governors Association. The literature has shown that permitting nurse practitioners to practice the full extent of their knowledge and training results in increased access to medical care, cost-effective health care, other modalities of healthcare delivery, and protection of the choice of patients. Several studies have shown that favorable practice environments, that is, states with full practice authority, were more likely to have nurse practitioners serve in rural and underserved areas. Healthcare costs decrease when nurse practitioners incorporated health promotion and disease prevention. One research study from the Journal of American Medical Association, which compared the care and resource utilization of nurse practitioners and physicians for 1,316 randomly assigned patients, showed comparable outcomes for patients treated by a nurse practitioner and a physician. And the research studies show that APRNs provide comparable quality of care to their physician counterparts. Furthermore, there are over 50 years of research which confirms quality of care and a high level of patient satisfaction that patients have in nurse practitioners. Nurse practitioners have always shared a complementary role with our physician colleagues. And as our island population face even greater challenges in our high-cost healthcare system, we are all called to use the best of our clinical knowledge and skill to address the health disparities among race, age, and socioeconomic groups. The health of our island today reflects its fragile primary care health system. Modernizing our advanced practice nurse law is a critical piece that can be implemented to improve primary care services, especially for those individuals who lack health insurance or are underinsured. To ensure timely, cost-effective, quality health care, the currently outdated nurse practice laws must be changed to allow advanced practice nurses to practice to the full scope of their education and skill. For these reasons, I ask the committee for a favorable vote for Bill 201-34. Thank you.
Thank you very much, Dr. Hitosis. Ms. Tyron?
Good morning, Senators. I'm Stephanie Tyron. I'm the newest advanced practice registered nurse on the block, I believe. Yes. Just graduated last April and got my license in July, I believe it is. And I started working in October. And a lot of what I've got written is pretty much in line with what has already been read. So I'm just going to read a small little informal personal message, I guess. In the clinic I currently practice in, it is only myself, my collaborating physician, and one other provider. That one other provider only sees patients 1 to 2 days a week maybe 2 to 3 hours a day. So that just leaves me and my collaborative physician. Between the two of us, we have a large clinic population, large patient population. My physician is about 2 to 3 years away from retiring. Where does that leave both his patients and mine that I have established care with, that have established care with me, that have been in our clinic for many years? With a collaborative agreement in place, I would have to leave the practice if we don't find another physician to take over for him, or God forbid something happened to him. This not only leaves me seeking out another place to practice or another physician to work with, but this leaves the patients that we care for basically on their own to look for primary care physicians. And a lot of the patients that we take care of are our local population with lots of comorbid diseases. Okay? 2 short years ago, 2 pillars in our medical community passed away fairly quickly, Dr. Perez and Dr. Erickson. And with that, unfortunately, that left their patients, some of them with significant comorbid health histories as well, seeking primary care from physicians who were no longer accepting new patients or who could only take small handfuls at a time because their practice was also robust. This is not what we want for our patients. It's not what I want as a provider. I value continuity of care. I have already established healthcare responsibilities with my patients and the physicians, and would expect to keep them in my care well after he retires or well after he decides he's got to take care of himself. So I strongly request, urge that we get this bill passed as soon as we can. I fear for the care I fear for the care of my patients because I've got a short time if my physician decides that it's time to retire. Thank you.
Thank you very much. Sir.
Good morning. Morning. My name is Greg Woodard. I'm a nurse practitioner. I work at GRMC in the oncology department. I've been a nurse practitioner for about 12 years, and I'm also certified as an advanced care oncology provider. So what I wanted to do is just kind of give some practical applications of how Guam's current law can affect access to care. And that's a big thing that we're going to provide is access to care. So I work for a specialist, an oncologist, and last time I checked, her schedule was booked for the next 3 months. So if you have a patient with an emergent oncologic condition, then we need to get them into the clinic quickly. And so I provide a means to do that. We can go ahead and get the patient into the clinic, get the preliminary lab work done, and then the patient can return and have this lab work in place so the oncologist can move on with their treatment. So I think this is good in that nurse practitioners improve the access to care, and I think that's an issue on Guam because there's a limited number of specialists. So what would change with this law if it's passed is the dropping of the collaborative practice. I don't think that in reality that will change because if a patient comes into my clinic and they have an acute abdomen, let's say, well, I'm going to get on a phone to a surgeon and I'm going to call him and collaborate with him. That's not going to change. We all collaborate, physicians, nurse practitioners, physical therapists, there's always this collaboration that goes on. So again, specialists on Guam kind of come and go. It's hard to keep an oncologist or a neurologist on Guam. And a lot of times, like she was mentioning, patients kind of get left in the lurch. The continuity of care is not there. So if the oncologist leaves and people are getting, active chemotherapy treatments, well, that kind of needs to continue till the new provider can come in. I don't practice beyond my scope, and I'm not diagnosing cancer and formulating the care plans, but I can continue the chemotherapies that have already been prescribed, thereby keeping the patient's treatment plan going. And I think I wanted to illustrate practically how this law has affected me. I had a patient fairly recently whose family had elected hospice care. There was no more that we could do as far as chemotherapy goes. So unfortunately, my provider was off the island, and I can't, as the law is now, prescribe hospice care. So what ended up happening with that patient who had wanted to go home and spend their final days at home was they had to be admitted to the hospital for care. And so this really increased the cost to the healthcare system, and it was unnecessary because, you know, I can prescribe hospice care to patients. And in states where I previously worked, we did that. So I think that the law needs to be updated, and I would ask for your support in doing that. Thank you.
Thank you very much, sir. And Ms. Ashley?
Hi, good morning. My name is Ashley Arturo. I'm a fairly new family nurse practitioner. I've been working for almost a year now. I'd just like to share how I actually became a nurse practitioner. So I used to work for the Department of Public Health. And as a registered nurse, you know, these people are one of the, you know, the population that need the most access to care. So it's very frustrating when I would see a lot of patients who'd come, you know, children that come from their school nurse and they say, oh, I can't go back to school because I need a physician or I need a doctor's visit so that I can have my paper signed saying that I'm clear and I'm not contagious, even though they have been, you know, they've been well for more than a week already, but they're not allowed to go back to school. But the schedules are always so tight because we have a shortage of providers that we can't get them a simple visit to get this paper signed without being seen. So, you know, for these types of visits, those really don't need to be seen by physicians. And a lot of times, you know, as a nurse practitioner, we're partners in healthcare, and we can provide that extra service, you know, that we could limit the amount of visits that need to go to physicians and kind of help alleviate that shortage. I just recently also completed my 1,000 hours of prescriptive authority, and it's also a very frustrating thing when you see your patient, they wait for you, you discuss your treatment, the management, but then they have to wait another 20 minutes in the room until I can find someone down the hall to sign the script for me, even though, you know, it's a very routine medication to give. So that's also another barrier to healthcare. I'd also like to share that I really hope that you pass this bill, Bill 201-34. One of the things, at least from experience, that patients have told me so far is one of the nice things about an APRN or a nurse practitioner is that we actually listen to them. A lot of patients, they feel very rushed. They'll see their doctor for 5 minutes, and then the next thing you know, they're out the room and didn't understand anything they just said. As part of a nurse, you know, in the beginning of your 101 classes, the first thing you're taught is the nursing care plan, how to care, how to speak with a patient, how to interview them, and, you know, therapeutic ways to speak with them. So I hope that with this new bill eliminating that collaborative authority, that there would be more access for more patients to receive health care who are not currently getting that right now. Thank you.
Great. Thank you very much, Ashley. Is there anyone else who wishes to testify on this, please? You can please come forward. Just please state your name.
Hi. Good morning. My name is Dahlia Sapalo. I'm a registered nurse, and prior to where I am now, I was working at the Guam Memorial Hospital for 7 years in the telemetry progressive care unit. As part of my duties, I would do general admission assessments, and part of those is to figure out why exactly these patients were admitted to the hospital with acute conditions. A lot of the times, the patients of mine that were Medicaid patients, MIP patients, These are patients usually seen at Department of Public Health for their care. And as Ashley had stated, they were not able to get care because they couldn't get an appointment because there were not enough healthcare providers. So these people could have had the medications and the treatments necessary to keep their chronic conditions maintained. However, they did not have access to care. And so that was part of the reason why I decided to go back to school to become a nurse practitioner. And right now, as a student, after finishing my healthcare policy and my health prevention classes, I was required to do a lot of research into, for my assignments, and I actually brought some research articles that would back exactly what Carla, Kevin, and Greg, what they have all said. And these are evidence-based research articles that were published in peer-reviewed journals, stating that nurse practitioners have actually been able to provide high-quality care, increase access to care, and also decrease healthcare costs. And this would be important for our Medicaid MIP patients on Guam. Now, speaking as an oncology nurse navigator, right now I work for Guam Cancer Care, and I have worked directly with Greg Woodard. One of the problems that I came into is, as part of my job, we give our patients access. We bridge the gaps in healthcare, basically. We help find resources for them to pay for their chemotherapy and their radiation treatments. Recently, I had an instance where a patient, in applying to another organization for financial assistance, the organization rejected the application because it was signed by a nurse practitioner. Now, this created a barrier and a delay in care because they were not able to get that financial assistance to pay for their treatment. So from my standpoint, as it is right now, removing barriers to care by allowing full scope of practice would definitely help the people of our island. Thank you.
Thank you very much, Dahlia. I'll recognize the prime sponsor of the legislation, Senator Torres, for any questions or comments.
Thank you very much for helping those of us who are interested in supporting the bill and may have some questions about what it actually means to understand the practical side. And I think what was so important was your emphasis on the access to care and how we do have a population that ends up in a much worse scenario because you don't have the preemptive care that, an advanced practice registered nurse can offer. I just want to extend to you our gratitude for taking the time to not only invest in the crafting of this bill, but in also helping us to understand in a very practical way why it is so necessary. And hopefully that the messages that you bring and your professional observation will resonate well with my colleagues, and that we can maybe get this on for voting in January. And I just wanted to extend my holiday greetings to you and to thank you also for what you do to help with our quality of life on Guam. And Carla, congratulations on your upcoming graduation. Stephanie, congratulations for being the new kid on the block. And Ashley, I'm glad that you recognize, how important your role is in the community and in healthcare provision. So si Zeus Masi. And Greg and Kevin, and Rose, of course, you've always had my respect and continue to do your good job. Thank you very much.
Thank you very much, Senator Torres. Vice Speaker?
Thank you for all your testimony and all your work. You're all performing very, very crucial and critical work for the people of Guam. So, Sidzus Ma'asi. But I do have a couple questions, I guess. Thank you for the explanations. Those were very helpful. Do any of the 22 states that have adopted this type of legislation, have they divided the one, like do some states get rid of the collaborative agreement but still keep the 1,000 hours before you can do prescriptions or some kind of combination of that? Or do all 22 states have eliminated both requirements?
I believe I can answer that for you, Senator. So these states, thank you. These states that have full practice authority have eliminated the 1,000 hours of practice hours needed before a prescription before the application for prescriptive authority. Now, a lot of these old statutes didn't have evidence to back that requirement back then, and because they were dated even over a couple decades ago, they still carried over. What has changed over the course of time is the training for advanced practice nurses and the amount of clinical hours that are built into graduate programs at the master's and doctorate level. And these hours require some anywhere from 600 to even 1,000 hours of clinical time that's already built into the education. So when nurse practitioners are done with their graduate study, they are ready to hit the ground running. This particular requirement is a barrier for them to see patients. It's almost redundant and treating them as if they were students.
But so some of the 22 states still maintain the collaborative agreement requirement?
The ones that have full practice authority do not maintain the collaborative agreement.
Could we get a breakdown if there are any states?
I can send you the AANP map that lists what states. So they break it down into 3 categories. One is completely restrictive, one is partially restrictive, and then the one is full practice.
Okay, great.
So it breaks it down, and in fact, the vast majority of them are either partially restrictive, where they have 1 or 2 requirements that makes you collaborate with a physician, whether it's like you identify a physician, not a written agreement, but okay, this is going to be my mentor. Okay. Versus, there's very, very few states that are still restrictive. And Guam happens to be one of those few jurisdictions that's completely restrictive.
I thought it would be 50 minus 22.
22 is full practice. And then you still have some states that have a limited practice.
So 22 full practice.
22 full practice. Some are limited, and then there's only a handful that are still restricted.
Okay, that map would be very helpful. Thank you.
I can definitely forward that to you.
Great, thanks. And then a lot of the problems that you're describing, I appreciate that if all nurse practitioners are fully authorized, it would eliminate the shortage of doctors, but I still see that some of the things you're describing, like doctors going off island, I mean, these are perennial problems with the shortage of doctors too. Some of them, if they're not your patients, they're the doctor's patients. I mean, they're going to be out of luck when the doctor changes location or quits practice or things like that. But I see the need for increased providers, right? Wait, I have one more question. I think is why are there specific lists in this bill regarding the focus? It says the APRN shall focus its practice in 1 or more of the following populations: family, individual across the lifespan, adult, gerontology, neonatal, pediatrics, women health. What is this list for? Is this a standard national list of, is it trying to say you're not going to do certain areas, or what is the purpose of the list, I guess?
Unlike how medicine focuses on specific areas of organ systems, treating patients, nurse practitioners focuses on populations for healthcare delivery. So these represent different specialty areas that nurse practitioners can go into. For example, family practice, mental health psychiatry, women's health, pediatrics. And so in general, advanced practice nurses are trained as primary care providers, most of whom serve in the outpatient setting. And we find that when we focus on populations this way, we're more comprehensive rather than breaking down these different groups into cardiology, pulmonary, renal. And that's how we are trained as nurses in terms of thinking holistically to provide care to patients and communities.
All right.
And
Does this list...
we also took a lot of the language from this bill from state, like the Model Practice Act,
Okay.
and those designations, just to elaborate on Kevin's, they're actually like the subspecialties. So when I'm going to enter my care, I can choose, you know, what population I want to treat and become specialized in that. So that's where that list originates from.
Senator, if I may just...
Well, for example, I don't see oncology here, right? Pardon? Oh, sorry.
Oh, that's okay. No, I just wanted to add that with regards to population, I myself as an adult gerontological nurse practitioner, it essentially equates to internal medicine, but in a handout that I provide my patients who don't understand what nurse practitioners are, to the ones who are new to me, I hand them a printout that basically states the difference between myself and a physician treats diseases. The nurse practitioner treats the person and their ailments. They generally treat the whole of the person, where we factor in what's caused it, how can we fix it, how can we prevent it in the home, and educate them about the disease process. But the physicians treat disease processes. We treat the person, if that makes any sense.
All right. So I guess, yeah, just so to be very clear, so this list really does not intend to restrict practice to these certain areas. It's just intended to almost for educational purposes. All right. And then what about this collaboration agreement with a physician? I can see a benefit of it in that you have a physician who's at your call, who you have a relationship in writing with, and they're pretty much responsible, so they have to answer. And without one in writing, I mean, you say, for example, you were at GRMC, the oncologist was gone, and you were unable to get another doctor at GRMC to sign that, to allow hospice care for the one patient. I'm concerned about that. Like, so that's the one Dr. Lee's. What about all the other doctors at GRMC? Why were they not able to do that? And so, while, I mean, I can see why you would want this, I also think for your benefit, you get, I mean, if we can make maybe some other changes where you do lock up with the doctor that has to answer all your questions and has to respond when you need anything in addition. I mean, perhaps, or are you saying that you will only need specialists after you, or would you need MDs for any other purpose, general MDs, or?
You want to talk first, or you want me to talk first?
The collaboration and consultation is always ongoing with all our providers in any healthcare discipline. However, there are instances where the collaborative agreement can have negative consequences in terms of how that relationship happens. Anecdotally, there have been issues where a collaborative agreement has existed between a physician and a nurse practitioner, and they wouldn't communicate with each other, and they severed the contract, and this would limit the nurse practitioner in terms of not being able to work, as well as maybe a provider using it as a threat or a punitive kind of relationship with that dyad. And so these collaborations always exist. We always curbside with our physician colleagues no matter what specialty or who they are. But the consequences of having a written agreement with someone really restricts us in terms of it locks us in, and it doesn't give us leeway if we have to make provisions for caring for our patients or if the communication breaks down.
And I just want to comment also. When you have this, I know at GRMC when I did my clinical hours, us nurse practitioners always had a physician in-house rotating who would be our consultant on every matter. But that wasn't necessarily who their collaborative agreement is. And so to lock in just one person is very difficult. And not only that, but you're putting a tremendous amount of liability also on that physician because that physician doesn't want to incur that extra amount of liability for the nurse practitioner that they don't really know. Like, we can't even practice with the person and demonstrate our skills until that collaborative agreement is in place. Would you just want to take on someone blindsidedly? Probably not. And so it's very difficult, and it puts this extra burden on the physician, and it's kind of like the physician doesn't know how much they need to supervise, how much they need to double check everything, because that's their license. And if we have our own independent license and we don't need that, it's our liability is on ourselves. And we know our scope of practice. We know when to ask for help. We're not going to go in there and blindly do things. And further, with that hospice situation, I can imagine it, because a lot of physicians won't want to sign, or other providers sign off on entering someone into a care if they've never even seen the patient. And it doesn't matter that it's the collaborative agreement or not, but I mean, they could have found, if Greg had a question like, I really don't know if I should start this person on this medication, any physician would agree to that. But no physician's going to agree to resume care or start care on someone who's not their patient.
All right, thank you. What about, does this bill then, would it equate a new graduate with someone with years of experience? That's what it looks like to me. Is that correct?
Just to comment, a lot of us had already many years of experience as registered nurses directly with patients on the floor and directly with the physicians, and we understand the type of care that the physicians provide. When we go into school, and correct me if I'm wrong, some nurse practitioner programs actually require several years as a registered nurse in acute care or an internal medicine arena, so that we have knowledge of almost all parts of what we're treating, right? Not just specialty. We choose our specialties when we go into the program. So when we come out and we're seeing patients, we have many years of experience behind us. We now have the advanced education to be able to diagnose, prescribe, treat, manage, follow through. And at this point, my physician, he trusts me, I trust him, but if he and I both know that our patient just needs some small little, just like Ashley mentioned, some small little treatment that I could have just signed over for, again, like Carla said, I have to wait. I have to wait until he's done seeing his patients, essentially making my patients wait. And this is just double work for one care, double work for one care. I mean, I hope that answers your question. We have lots of years of experience before we do go out and practice. So new APRNs are not new in the sense that they went into college with nothing behind them. They went into the nurse practitioner program with many years and experience as registered nurses in acute arenas of nursing and in primary cares of nursing.
But in prescribing medicine, if we remove the 1,000 hours in collaboration, then that would be the first time ever they have ever done that, right?
To sign the prescription,
New
yes.
graduates would be equal to those like you, all with many years of experience, right?
Yes.
Well, in our clinical hours, in our training, so right now I'm doing my clinical hours for it. I actually see the patients on my own, and then my provider will come in after me, and then I write the prescriptions out how I would want it, and then my physician signs off on it, or my nurse practitioner signs off on it. So it's training us to actually do our role outside. And I'm not talking about just a handful of hours. I'm talking I will have about over 1,000 hours of doing just clinical work, not any studying for tests or doing that, just working in an actual healthcare facility and doing the treatment plans with patients.
How many hours did you say?
Over 1,000, because I'm doing a dual role. So,
what do you mean by that? Dual
so
role?
I'm getting my degree in both family practice and in acute care. So it's a dual program role, and I will have over 1,000 hours of clinical experience.
So does every nurse practitioner have a specialty when they graduate?
Yes.
Okay.
So everyone does, and you have to pass a national licensing exam in
great.
your specialty.
And do you think we need that the bill qualifies the schools, I guess? Are all
Yes.
schools requiring clinical
So,
hours? Do you think they're all
yes.
the same in
So
that
in the
regard?
language, they have to be an accredited program, and the accreditation process is actually very tedious. I mean, it's not anything. So you have to be an accredited school, able to sit for that national licensure certification and pass it.
All right.
In order to apply for licensure on Guam.
All right. Okay. Thank you. Yes, Greg?
So, put it in context a little bit. When you're new out of school, you know that every prescription you write is you. There's a lot of responsibility. So, like I remember before I would prescribe an antibiotic, which is pretty benign, I would look up all the side effects and I would be very sure that what I was doing was safe because, I mean, you want to help the patients, you don't want to hurt the patients. So just like any provider out of school, those first few years, you're very cautious. And I don't know that the 1,000 hours does much more than the personal responsibility you've already got.
Thank you very much, Vice Speaker Senator Lee.
Thank you, Mr. Chair, and I also want to thank the sponsor of this bill. I think it's very timely, and I also want to thank all of you for providing the care that you do to our community, but also for taking the time to provide us with the information that we need to make a decision on this piece of legislation. What I'm hearing from you is that this bill would increase access. It would provide for additional continuity of care, which is extremely important, and then also just give patients maybe more of a choice, right? Additional choice. So as the chair on our Committee on Workforce Development, I think a lack of skilled nurses on Guam, kind of coupled with our current H2 situation, or H2 crisis, is really concerning to me, and I know to many members of our community. Do you feel that this bill will encourage more people to go into the nursing field, or do you think it'll inhibit that? And I guess I want to pose that question to, to Dahlia, to Ashley, to Carla, all of you, if you could just maybe respond to that.
Can I start first? Oh.
Go ahead.
Speaking from the Guam Board of Nurse Examiners and seeing the crisis in terms of our nurses leave island, there is a limit in terms of career advancement that our nurses in Guam have. And they're going to leave here for other pastures where it's greener. This represents an opportunity for our community to advance in different ways, in different fields of nursing, that we can retain the best and brightest here in Guam. And that's a critical issue. We see droves of our registered nurses leave our hospitals stateside.
Thank you.
Again, speaking from working in the hospital, I have had to work so many extra hours and cover shifts when my colleagues have left the island, like he said, for greener and better pastures. So again, I can attest to how much the island needs additional healthcare providers in the form of nurse practitioners. And again, that is exactly what drove me to go back to school and to just push through it, just to help decrease the burden on this island. And so, yeah.
I think it was a pretty resounding, everybody kind of nodded their head that it would, so
Senator, if I may just,
Sure.
I have a classmate who I graduated with in my BSN program, UOG's nursing program, and of the class, 2 of us are nurse practitioners. She's an advanced practice registered nurse as well, and she wants to come back home and practice, but she doesn't care for any of the restrictions at all. She's currently, I believe she's in Colorado. Cheryl Valera. Cheryl specializes in neonatal renal transplants. We have our local community educated and practicing who want to come back home, but she does not care for any of the restrictions. I mean, I hope that gives you just a small little, yes, we do have colleagues who are APRNs or folks who do want to get the advanced practice degrees, but are not enticed because of the restrictions. It would generally give them the same responsibilities as the registered nurse if they're still always going to be under the wing of a physician or if it's a mandate. So I hope that answers your question.
Thank you. And also to just kind of tag on to some of the concerns that was raised by the Vice Speaker. I was looking through the bill, and on pages 60 and 61, I know that it kind of addresses continuing education requirements and discipline. And Craig, I know you were mentioning that, the first few years of your, practicing directly on your own with patients, you're even more concerned about the way, making sure that you're going by the book and doing additional research to make sure that the medicine that you might be prescribing patients or the care that you're giving is top notch. You don't want to make any mistakes, and I can imagine what that pressure is like. So I wanted to ask specifically about the continuing education requirements in this bill and the discipline requirements in this bill. How do those compare to other states and territories? Is it stringent enough when people make mistakes? I wanted to get some feedback from all of you.
When we drafted this bill, we took from the National Council State Board of Nursing the template for their model for advanced practice nurses. And what we also looked at were legislation or statutes from progressive states such as Arizona and Washington State and Nevada that made sure that we not only ensured strong continuing education for advanced practice, but also discipline just in case there are violations in their scope of practice. And I think it's pretty sound.
Thank you. Carla?
I am also a registered nurse of Hawaii, and I can tell you they require 0 continuing education hours for license renewal. So Guam, I think, has more than sufficient CE requirements for advanced practice nurses.
Okay, great. And again, I just want to thank you all for your time and for putting the energy and the effort into, working with our sponsor and drafting this bill, and I look forward to supporting it. Thank you.
Thank you, Senator Lee. Senator Torres, you have a follow-up?
Dahlia, I think I was at your pinning ceremony when you first became a nurse, and I just want to also congratulate you on pursuing your further education and career development. It's very exciting to see that our healthcare system is in good hands with very compassionate and young, dynamic people like yourself. So thank you. And I also wanted to just also point out that the educational requirements, as you mentioned, are quite lengthy in section 5.6. So anybody that has any doubts about the competency and the extent of training of APRNs, it's well documented in this legislation. But more so, what we're really trying to do is bring our Nurse Practice Act in compliance with National State Board of Nursing consensus models for APRNs. So it's not, we're not trying to create something that isn't sound and well established. But I think for the general public, it gives us some confidence that we're up to par with what is the model standard with this legislation. And I just want to say Suzus Maasi again, and Merry Christmas to everybody.
Thank you. I just wanted to also ask one more question, and that is, so DPH in public health, I can see that, if they would allow, if this is passed and they would allow more or hire more nurse practitioners, they could see more patients, and you're saying that they're not able to see enough patients as it is?
Definitely not. And I'm sure Senator Rodriguez can probably agree with me. That's why we do these outreaches, is because a lot of these people, they can't even ride the bus to the clinic. And when they do find the time to, there's no appointment available. And they're told that they have to come back, the next day, a week from them. And they just used all of their money to, buy food at the store for the children. So I think that would also significantly improve the access there. And in addition to that, one of the problems, the reason why it's difficult to really recruit there is because of the pay. Just nationally on Guam, we do have one of maybe the least, pay scale. And so that would also be a good motivator for people to come to Guam, especially to the community health centers to help out the people.
Does this bill change the pay scale? I mean, do
Well,
you think
that's
it
what we would hope to do in the future, and for now, we're kind of just hoping that this will be a stepping stone towards that.
All right, and so my curiosity is Guam Memorial Hospital. If we pass a bill like this, and in particular for Guam Memorial Hospital, and a lot of you have experience there, in what way do you think that this bill, or allowing a nurse practitioner to replace somebody, I guess at GMH, would benefit? I mean, are there areas, perhaps oncology or other, like I think some of you described certain particular areas where they have in other jurisdictions used nurse practitioners to lead those programs. So where at GMH would you propose that be done?
I believe they can help to augment the ER. I mean, there's been several times I've known that the ER has worked with only one provider and has to gone on divert because there's only one provider in the ER, and you can't see the vast majority of patients. I mean, the way GRMC and GMH are spread out is GMH gets, everything from Tamuning down south, and GRMC gets everything from north to, north central. So it really hurts the island when you don't have both ERs running to their full capacity. Another thing is urgent care at GMH. I mean, urgent care has been kind of touch and go lately, and I really truly believe for those minor ailments that occur outside of working hours, because everyone who has a child knows they don't get sick until after school or on weekends, right, when your primary care provider is not available. So that would help to increase access to care. And then, like I said, those heart failure clinics, diabetes clinics, Coumadin clinics, wound care clinics, those are all areas that nurse practitioners have been proven to run and be effective for the patients. Because you can come in for a dressing change and not necessarily have to go see the provider, but just come in to the nurse practitioner, we can look at your wound, we can assess your wound, we can treat your wound, and then send you on your way.
Yes, that's very helpful. Thank you.
So if I may, Senator, as a primary care internal medicine umbrella, but adult gerontology, and establishing my own patients, I would love to be able to follow their care through admission, should they get admitted, but I wouldn't be able to do that. I would have to leave it in the hands of another physician, maybe my own physician, to go and visit the patient, who he knows nothing about. So access with GMH would be very big for someone like me who does primary care. Because my patients get admitted, I can't do anything about it. I'd have to leave it in the hands of the hospitalist or in the hands of my collaborative physician, who doesn't admit, by the way. But I would like to follow my own patients through admission in the hospital.
If I may.
If I could. So if Ashley can't see the patients at public health, I'll see them in the ER. And I used to work in the ER. And so it's more cost effective if Ashley can see them at public health. You can imagine the charge for antibiotics there. But if they're unable to get in, they're going to come to the ED, and then imagine the cost of that visit. So, I can see whereas it would be worthwhile to have them seen outside. Yeah.
Okay.
This might be ignorant, but yes?
I'm sorry, one more. I think this bill is not seeking to replace any of the physicians or the care they provide, but to augment those that are already there. As a nurse from GMH working the graveyard shift, you have a patient in extreme pain, okay? And if you can't get a hold of their doctor, and they had a nurse practitioner there, they could then prescribe a pain management program for them that would help. In the middle of the night, it's hard to get that. And then if you do get a hold of a nurse practitioner, with the barriers in place, the nurse practitioner would then still try to have to get a hold of a doctor to address their pain needs. And
So what are you suggesting, that a nurse practitioner be on every floor or something, or on call in addition, and then you're going to take over a particular doctor's
no,
care
again,
of that patient?
not to replace.
Because
to
right
augment.
now, if you can't get a hold of one doctor, what do you do at GMH?
Well, if you can't get a hold of one doctor, so their primary or attending doctor, then you would have to try to get a hold of a specialist if they have a specialist on their case. If you can't get a hold of a specialist, you would go up to the medical director. So it's a lot of chain of command. And when you're taking care of a patient who's in extreme amount of pain, you would have to empathize and see, like, how long would you have to sit there and wait until you could get an order from someone? And if these particular barriers are removed, you get direct access through a nurse practitioner. Again, not that she or he is replacing a doctor, but that they are more accessible and able to treat somebody.
But does that occur at hospitals, that they would have a primary doctor
Yes, in
listed,
graveyard
and
shift.
then they would allow somebody else
Yes,
to...
they have
Graveyard shift.
what they call like on-call hospitalists, who that on-call hospitalist can be a nurse practitioner, and they work, usually 12 hours, and they're not necessarily the person taking care of them during the day, but they're there to respond to emergencies, answer calls, and they stay in-house. Yes.
All right, okay. All right, I guess that's very helpful. So, oh yes, so can you just describe, if I have to explain this to anybody in the public, I don't want to be totally ignorant, and I am right now, so please help me. What are the limits then of a nurse practitioner? What is the difference between a nurse practitioner and a doctor? Like, well, when would you need to go to an MD versus a nurse practitioner? Are there none after this bill?
No. So our training is very specific. So if I see a patient, for example, who comes in with heart failure, and I'm not trained in heart failure, then I'm going to refer them to a physician. If I see a patient that comes in with a rash, and I tried treating it and it's not really what I believe, I will refer to a dermatologist. So it's very individualized care, and it's not steadfast. Like, every patient who has diabetes will go see this. Every patient who has a wound will go to this. No, it's very individualized care. This bill doesn't eliminate that collaborative judgment or the boundaries that we know. We all have limitations, and we know when something is beyond our control or beyond our expertise. And that's when we usually refer to a physician or a specialist.
But in writing, there's no limit. There's no limit to the prescription authority, right? It would be equal to any other MD. Is that correct?
No.
No?
There are regulations to our prescriptive authority, especially with our controlled substances. The federal DEA mandates what exactly nurse practitioners can prescribe, and we follow those federal mandates. In terms of...
But that would be also very helpful if you could submit that.
Yeah.
So we could have
And
that
then,
list
and then in terms of our care, our scope of practice is listed in the rules and regs, I believe, where it's very detailed as to what we can do. I mean, we're not going to go in and perform surgery on somebody,
right?
But I can suture a patient. I can definitely refer to surgery.
Yes. Okay. So I see the list of the scope of practice, and I thought that was helpful. But can we? All right. So in order to, all right. Okay, I'll leave it at that then for now. All right. Thank you very much. That's been very helpful. Thank you.
Thank you very much, Vice Speaker. Thank you all for being here and providing your testimony and insight on this measure. I want to thank Senator Torres for spearheading this and working with you to get this moved forward. This is really in line with the committee's efforts the past few years to expand access to care, whether it be physicians or nurse practitioners. This is something that the committee has determined is a real need in our community, and so this is one step in moving in that direction. So I want to thank you for that. I know that Dr. Itosis, you're working on the entire Nurse Practice Act that needs to be revised, and so we look forward to getting something as well and moving that forward here. I just have one question. As we move forward with the medical marijuana law that we have now, in any of the 22 states that you've indicated have full practice, any of those states that allow medical cannabis, what is the role of a nurse practitioner in that, if any?
At this point in time, with regard to medical marijuana, that is something specialized that advanced practice nurses don't want to delve in. There are very specific requirements for prescribers of that. I think some of that is evolving at this point in time. We have not addressed that issue in any of our practice law currently.
So none of the full practice states have addressed that. So none of them are.
I think there's states such as Colorado that has, yes.
So what do they do?
I believe Colorado and I think Washington toyed with it too. They prescribe marijuana the same as physicians. They're given the same rights and authority to do so as modeling after physicians.
Okay, so do you, and the reason why I asked that, because one of the challenges we face, at least early on in moving the program forward, is the, the lack of physicians who want to or who are willing to participate. And that is one stumbling block in moving the program forward. We're in that phase now with our rules and regulations to looking at, where we need to, what we need to address, right? And since we're here now, and we are, if this passes, removing a lot of the barriers that you face now in really being able to fully practice. That's something that I think we need to really look into more. And so you said 2 states, Colorado and what state? Washington State allow that. So that's worth us, the committee, at least looking into and working with you to see if there's any possibilities there. But is that something that you, at least for you here, have looked at? And, do you have an opinion?
May I? I was a hospice nurse for about 8 years, and I'm not going to represent the group. I'll represent myself as a provider. I have no issues with it, and I would, if allowed to, prescribe for my dying patients for sure, because I've seen them in their homes get better actually with their own personal stash, I guess you would say. But I personally don't have any issues prescribing it if it's necessary, especially for my dying patients. If I could refer to hospice if this barriers get removed, that's my opinion.
Okay, thank you very much. So if we were to address that, I know we would have to authorize that in the rules and regulations as well, but in this bill, the bill before us, 201, is there something here that we need to include, any language that would make that happen?
I think there should be some sort of safety maybe added or amended to the current bill. While it allows us full practice to be able to prescribe, many of us feel that it's well out of our scope. So I think it's something worth looking into that may need an amendment to the current bill if that's the case.
So may I ask, since you represent the chair of the Guam Board of Nurse Examiners, to provide us a proposed amendment, if any, before we close the report on this, because that's something the committee would like to explore further, but would like guidance from you on how we can move that forward.
Sure, absolutely,
okay.
Senator.
Great, thank you very much. Anything else, Senator? There's nothing else. Yes, sir.
So oncology, medical marijuana is used as an appetite stimulant, and it's also used as anti-nausea medication. There are some prescription drugs, Marinol comes to mind, that is the active ingredient in marijuana. And we've used that for years as an appetite stimulant. So, I mean, there are specific indications for it. And typically, there is a certification, I believe, that if you're prescribing marijuana, that you sit for the specialty training. And after you've gone through that training, then, the comfort level, I imagine, would be there with that.
Sorry, can you repeat that and expand on that? So you're saying as a nurse practitioner, you need to have a specialty?
Yeah, you need to go, just like opiate withdrawal, there's a medication that you have to sit through a special certification or training before you can be recognized to prescribe that particular medication. It's Suboxone, I believe. Marijuana is much the same way, that you attend this class, they teach you what the indications are and that kind of thing, and you get a certification at the end of that. And once you have that, then you can make the argument that, I can treat these patients effectively. I came from Arizona, where the law was kind of liberal, and so it helps as an appetite stimulant, and it helps with nausea, but some of the indications I think we're all a little nervous about, like anxiety and that kind of thing. I can see it in oncology patients for those indications, but I can't speak to anti-anxiety and things like that for marijuana.
Okay, so you hit it where my, at least what I'm thinking and what I've been thinking is that I really would like to see this more available to those patients, to cancer patients,
yeah,
to those that really need it. I'm not saying people that have anxiety or any others don't need it, but sure, that's my focus and where I want to see this provided to is to cancer patients. And so perhaps that could be some sort of compromise or some sort of start, is that if we allow this for you to be able to do it, is limited to oncology patients. Sure. Is that something that you think could work?
Yeah, I mean, there are other modalities to do that, but sometimes people tend to respond best to that. And if that's what works, yeah, I'm amenable to that.
Okay. So okay, thank you. So you're saying a training, you got to go through specific training first. Is that the same training physicians have to go to in order for them to not prescribe but certify a patient is eligible, or could?
Typically there is a certification, just like I have a advanced oncology nurse practitioner certification saying, that I've gone through training for oncology specifically. So when you get into these specialty areas, there's typically a certificate or a training that you attend prior to, just going out and doing this willy-nilly, right?
Okay. Okay, thank you. So we'll work with you.
Just wanted to add to that. And so there are certain classes of drugs where even physician colleagues need very specific training for. Take, for example, Suboxone. And that requires a certain DEA approval to be able to prescribe that medication, because that medication is fraught with a lot of side effects and could potentially be dangerous too. So I don't feel comfortable with regard to an average clinician saying that they can easily prescribe something like medical marijuana. I think there are certain kinds of specialty training that's needed for certain classes of drugs. And so that's something that maybe needs to be looked into more.
Okay, thank you. So we'll wait for some recommendation and guidance from you. Okay? So if there's nothing else, Rose, did you have anything else? If you could just press that button, please.
Okay. Senator, I'm really looking forward for you guys to approve this bill, because, this bill will open doors and how we maximize the value of our advanced nurse practitioner and providing a safe and effective care and in our island. And also, I am a preceptor. I wear so many hats, and most of you knows. This is really going to inspire our young students that now we're recognizing that, hey, they can practice here in Guam. The role of nursing is emerging, and it's going to be changing. And we are here for you. I know Senator Terlahi, we did a lot. We need to have a lot of education, and the scope of practice have changed. It's going to emerge. It's going to change in the next 10 years. So passing this bill will really open a lot of doors, and really being part of the healthcare team. There's a lot of concern about not having a collaboration. Collaboration and on patient care is always going to be there in the whole healthcare team, from physician to the nurse practitioner to the nurses and other multidisciplinary. It's always going to be there. So passing this bill is really going to open a lot of doors, and it's really going to improve our healthcare system here in Guam. I'm having an increased workforce. Thank you.
Thank you very much. So we'll continue to keep the record open on Bill 201. And if there's anyone else who wishes to provide written testimony, they can do so by submitting it to my office. Okay? Thank you very much. We'll now move on to Bill 201 or 202-34. I'd like to recognize the sponsor, Senator Torres.
Thank you, Mr. Chairman. Bill number 202-34 is an act to amend Section 12212.1 of Chapter 12, Title 10, Guam Code Annotated, relative to expanding access to physicians' professional profiles. This bill essentially will require the Guam Board of Medical Examiners to upgrade the information found on its website by providing pertinent information on the medical physicians it licenses on Guam. Under current Guam law, an inquiring member of the public is entitled to receive information on enforcement actions taken against a physician licensed on Guam by the board or by any other state board or licensing jurisdiction if they submit a request to the board, and then the board must then release the requested information within 4 working days. But the present law does not do enough to provide the public ready access to general professional information in order to make an informed decision when they're choosing a physician to provide medical care. Bill 202-34 will address this gap and further promote a culture of trust and self-policing amongst physicians when selecting healthcare professionals. Bill 202-34 will allow public greater access to physician information by requiring the Guam Board of Medical Examiners to have a physician profile readily available on their website. We believe that having this will benefit not just the patients but physicians as well, since they share a common goal of providing excellent, effective, and safe medical treatment to patients. And it'll also facilitate an atmosphere of transparency. But what we've done with Bill 202-34 is we're not creating anything that is not already the standard and the norm across the states. The website that is maintained by the Board of Medical Examiners is generally the repository of such information. And what I have done since introducing the bill is I've looked at other ways to further clarify areas where it is not specifically clear on what is meant by certain information that's listed. I've also contemplated putting in disclaimers so that if there's information that's reported, there's also an opportunity for further information and clarification. And what I've also contemplated doing is expanding so that we ensure that any information that is more personal in nature, not professional and public in nature, is more optional as opposed to mandatory. But in general, too, what this bill will do too is allow for information that is within the board's control to be listed on a website. And what the advantages that we have is that we want to make sure that it is clear, people have access to information, and it is clear about the physician's current status, for example, with their licenses, what specialties they may have, if there are complaints that are legitimately filed against them that are unresolved or that resulted in a settlement, what those mean. We want to provide clarification on what exactly settlements mean. And then also, I'm contemplating having it so that the burden is not so much on the medical examiner's board to put more than what is required, and also give them the opportunity to link up with other jurisdictions that might have information on physicians that are licensed in Guam. But in general, when you think about the nature of how we go about choosing physicians on Guam, there really isn't that much information available currently on the Guam website that is maintained by Department of Public Health. So what this bill does is it's an added measure to assist people in obtaining information that's pertinent to their choice of physicians on Guam, but it also acts as a good measure of physicians generally policing themselves, where if a physician puts himself out to have a certain specialty and they hold themselves out to be board certified, that we do know in fact that it's by the American Board of Medical Examiners, and their certifications are exactly what they purport it to be. So it's a good measure, a safe measure, a transparency measure, but it is also a measure that is not inconsistent with what the norm is, and it also is a good and I think timely way to upgrade certain reporting mechanisms that we have on island. So in a nutshell, that's what Bill 202-34 is. It's relative to the disclosure of physicians' professional profiles in a website that is presently maintained by the Board of Medical Examiners and the Department of Public Health.
Thank you very much, Senator. Ms. Carla Haddock.
Hello again. I just wanted to give my personal experience and why I think that this bill is needed. When I'm doing my nurse practitioner program, I had to have physicians as part of my preceptors, and my school required that I do a license verification on them. And they said, you know, all jurisdictions just go on the website and do a screenshot of the online verification. And I wrote to my school and I said, well, I'm sorry, Guam doesn't have that. And they said, okay, well, figure out how to get a license verification. I said, oh, okay, well, Guam has this. And it was just a PDF printout of all the physicians that obtained a license for that year. They said that won't do. It has to include their standing, whether or not they're in good standing, if they have any disciplinary action, and their specialty. And so I inquired with the Guam Board of Medical Examiners, how do I go about getting a physician's license? And they told me that I needed to have a written authorization from my physician in order to obtain that information. And I was like, I cannot believe this. This is ludicrous. Like, if a person wants to obtain a verification of someone's licensure when they're allowed to practice on Guam, shouldn't you be able to do so? Shouldn't that be public knowledge? And so creating this database and this website would really help for the people on Guam, because when you think about it, you can go to any other jurisdiction and type in a physician's name and you can see that. And I was kind of taken aback too, because you can do that for nurses. Currently on Guam, you can go to the website and you can get a license verification on any registered nurse on Guam, to include if they have any disciplinary action, if they're in good standing, what other jurisdictions they might be licensed in. And the way Guam physicians work is that we have so many people coming and going, and you know that. We have, you know, these short-term contract physicians from GMH and GRMC as well, and we don't know their backgrounds. And in choosing a physician, there's really no information to go off except for these public sites that aren't maintained, you know, like Rate My MD or whatever, but you don't know if that's trusted, verified information. So having this website would create verified, trusted information for the public, and you don't have to pay also that $20 fee to get a license verification on each physician. Thank you.
Thank you very much, Carla. Senator Torres, you have any questions? Vice Speaker?
I see that. So the bill would put what's already required to be disclosed within 4 working days. It would mandate this information be put on a website now. So immediately available, that is like restraining orders, interim suspensions, revocations, probations, letters of reprimand, infractions, civil judgments. So now those would be public.
Not only public, but just the fact that I don't have to get a written authorization from the provider in order to obtain that information.
Correct.
I mean, that to me just...
Yeah, it didn't seem like the original statute required written authorization, but that's what they were telling you.
Yes, that's what Guam Board requires of you. They require a written authorization
The
to
board.
be submitted. Yes,
The board was saying that. Okay,
Yes.
and then this would add that we're going to put up, and it seems to me this information, I would hope, would be easily available. So I share your concern. Yeah, the educational history, their employment history, jurisdictions where they're licensed or denied licensure. And you're saying that all of this information is already required by the board, so the board has it, and they
Yes,
will.
as part of the licensure application, all of that
Yes.
information is there.
All right, and I was going to ask you about the nurses, so I'm glad to hear that that's already available for nurses.
Yes.
I would assume if we did this for physicians, we would do this for the nurse practitioners also.
Yes.
That would be helpful for the public, and.
Yes.
All right. There are no physicians here, though. I'm curious about that, but all right. Thank you very much, Carla. Thank you.
Thank you, Vice Speaker. We'll ensure that we try to get some testimony from the physicians. Senator Torres, for any closing?
Yeah, just to, I did have the opportunity to meet with physicians, specifically the Board of Medical Examiners, and and then they gave me some very valuable tips about what is practical for them and what would be overburdensome for them. And so what we want to do is make sure that we don't put the board in a position where they have to verify or do anything beyond what they have in hand, and that there are certain disclaimers and protections to the board in terms of disclosure. So what I intend to do is I intend to make sure that the information provided is information that's readily available to the board, and that where we ask for specific disciplinary action or settlement information is more expounded, so that everybody understands their parameters, and then it would also protect the physicians against any unlawful disclosure of information. So there are ways that the board recommended that we could improve upon this language in the bill to make it clearer about what exactly is reportable information, where disclaimers are necessary, and if there's information that is more personal in nature, that it be optional as opposed to mandatory. So I do intend to work with the committee in setting forth those recommendations and to expounding upon the language so that it is very clear and explicit. But mostly it's not to burden or add an extra burden, but to just upgrade a system that's already in place.
Thank you very much, Senator Torres. There being no other individuals here to provide testimony, the committee will adjourn this public hearing on both Bill 201 and 202. The time now is 12:41. Thank you very much.